Hey, everybody. Welcome back to the Healthy, Wealthy, and Smart podcast. I am your host, Karen Litzy, owner of Karen Litzy Physical Therapy in New York City. And today we are going to be busting some myths and misconceptions, misinformation around menopause. And I joked before we went on the air, this would have to be like a 10-hour podcast, but it will not be 10 hours. We will keep it to around 40 minutes as usual. But I'm really happy to have on the program today a fellow New Yorker, Dr. Marcia Harris. She's a Columbia and Cornell trained surgeon turned hormone restoration pioneer who has helped over 10,000 midlife women reclaim their energy, sexual vitality, and quality of life. With over 40 years of clinical experience, she's challenging outdated menopause care with her groundbreaking total transformation protocol. If you're ready to ditch one size fits all medicine and learn what actually works for thriving through midlife, you will not want to miss today's episode. So get out those pens and notebooks or computers and start getting ready to take your notes. Dr. Harris, thank you for coming on the podcast.
Thank you so much for having me, Dr. Litzy.
I am thrilled. So, like I said, you've been at this for 40 plus years, but why did you decide to go this path? Why OBGYN care? Why care for women in midlife?
Well, I'll do two stories.
Perfect.
The first one, my mother passed in childbirth when I was 7.5 or 8 years old. And I used to say, I want to do something to make sure that other little boys and girls didn't lose their mommies. And that's actually what started it. Now, I'll tell you, I didn't stay there because when I started college, I was a speech and drama major. I wanted to be on Broadway, but I couldn't sing. So I came back. Actually, my dad sent the money for college. This was the end of the second year, sent the money for the third year, and gave me a big letter saying, do you see anybody looking like you on Broadway? And you can't sing. Okay. And I wrote void on the check and sent it back to him. I had never worked a day in my life. Okay, so here I was 16, 17 years old and never worked a day in my life, sent the money back to him and had to go out and find not one, not two, 3 jobs. I left home at 5:30 in the morning, got back at midnight or after, and graduated on time with honors, having 3 jobs.
Wow.
Pay for it to finish. So that's actually where the original idea of doing not just medicine, but OBGYN. I didn't know what it was at the time. I actually used to say I want to be a surgeon so that other little boys and girls won't lose their mommies. My mom had had a C-section.
Got it.
She had sickle cell disease. She was a mess. And when she had me, they told her not to have any more kids. She had another baby 4 years later, lost it. And they said, don't, if you get pregnant again, you're going to die. And so said, so done. So that's my story for how the OBGYN part comes into it. So I actually, when my dad sent the money, I changed my major from speech and drama to chemistry.
That's that is like opposite end of the spectrum there. Yeah.
Okay. So I changed to chemistry and then I got out of school. I worked first for a drug company for about 3 or 4 months and said, nah, I'm not going to spend the rest of my life shaking test tubes. And at that point was hired as a chemistry technician at Memorial Sloan Kettering. And that's when I said, okay, yeah, I'm going to medical school. I think I needed 3 courses, took the 3 courses and applied to medical school. So that's the medical school story.
Right.
Now, I did OBGYN. When I finished medical school, I actually did a year of internal medicine at Harlem Hospital
Mm-hmm.
and didn't like it was too sad. I mean, people were dying and
Mm-hmm.
so I then applied to OBGYN programs
Mm-hmm.
and I got into Weill Cornell,
Great program.
the New York hospital. Now we're talking about the early 70s,
Mm-hmm.
you know, and I was the eighth woman to ever go through the program. It was an old boys club.
What?
New York Hospital is the second oldest hospital in the country.
Mm-hmm.
The early 70s, when I showed up there, they didn't have a clue what to do with me. I was the eighth woman, the first Black one,
Mm-hmm.
the eighth woman to ever go through the program.
Like now, of course, it's so hard to believe, right? But we're
Hard
talking
to-
50 years ago.
We're talking 50 years ago. So I'm a true pioneer
Yeah.
in more ways than one.
Yeah. Yeah. Amazing. And so you get into Cornell, you go through your residency. Did you then go on to fellowship and
No, I went straight into practice. I
okay.
opened a practice on the east side. I mean,
Mm-hmm.
not far from where I am now, actually.
Mm-hmm.
65th and Madison
Mm-hmm.
is my first office. And then 72nd and First. I was at 65th and Madison for 8 or 9 years,
Mm-hmm.
72nd and First for 29 years.
Wow.
Yeah. I sold that. I retired. I walked in one Friday morning. I used to see patients, most of the week. I operated all day on Friday. And one Friday morning, it was right about now, it was actually October. I was driving down, I lived in Bergen County. I'm driving down 9W.
Mm-hmm.
And I basically said to myself, why are you still doing this? you know, totally and completely burnt out,
Mm.
you know, in my 60s, burnt out. I asked myself, why was I still doing this? And at that point, I went in, I had 3 major cases, did my cases, cleaned out my locker, and said to the girl at the desk, sayonara, I am not coming back up here. And every head in the nurse's station turned. Every head.
Mm-hmm.
What did she just say? I looked at them and the girl at the desk said, but doctor, you have cases scheduled next week and the week after. And I said, don't worry, they'll be rescheduled. I didn't even go back up there to say goodbye. I never went back up there. And by December, I had closed the practice
Mm-hmm.
and was on the beach in St. Lucia.
I mean, sounds like a good retirement, but yet here you
Here
are
I am.
back in practice.
Well, retirement lasted 3 months.
Okay. So you took a 3-month vacation. You took a sabbatical for 3 months.
Basically, yeah.
Okay.
I lay on the beach in St. Lucia for a month, went to Jamaica, lay on the beach there for a month, and I came back here, ran around New York, New Jersey, Connecticut for a month, and then said, okay, now what do I do?
Mm-hmm. Right. And now here you are concentrating on women. I should say women, your practice is both women and men.
It is.
But today we'll be focusing on the women part of it. So what made you say, okay, now I'm going to focus on women in midlife. I'm going to focus on these women going through perimenopause, entering menopause and beyond?
Well, that actually started before the retirement because I had one of the worst perimenopause into menopause that anybody could ever have. 10 to 15% of women have really severe symptoms. 10 to 15% of women have no symptoms, whatever. And then you've got the 70% in the middle, some with 4 or 10 or 15 or 20, varying amounts and for varying lengths of time. Let me put it this way. The nurses would see me get off the elevator at Cornell and duck into rooms.
Oh, no.
The hallways would clear.
Right. It was like the parting of the Red Sea when you walk down the hall.
Yep. They loved me. They were all my patients.
Yeah.
I delivered 50% of them.
Oh, my gosh.
They were all my patients. Nurses, doctors, they were all my patients. But for 2 weeks of the month, I was the nicest, sweetest person. For 2 weeks of the month, please don't come near me unless you wanted your head taken off.
Right.
Because I would scream for no reason. I would get 20 hot flashes a day. I was on the quality assurance committee and the resident selection committee. I remember one day in the boardroom, we're sitting there going over applications, and I get this hot flash and I rip off the white coat and then I rip off the jacket, and I'm looking at them saying, hope y'all have seen boobs before, because this blouse got to go.
Yeah.
Okay?
Yeah.
It was horrific. And I was so nasty. I would throw stuff. I would scream. I mean, you know what the nurses did? They looked at my feet, because I would, even operating, I would be in 4 and 5 inch heels.
Oh my gosh.
All day in the OR. When I got off the elevator, they would do this. Because if I was in my 5 inch heel, it was going to be a good day. If I was in flat shoes or sandals or sneakers or whatever, oh God, it's going to be that kind of a day.
Right.
Because I was insufferable. And I mean that. I was so bad. Now, the problem is that's right around the time all of this happened in the 80s. I did not do hormones then.
Right.
Even though I gave them to patients. But the question was, did they cause cancer and all of the above? There's a lot of cancer in my family and so on and so forth. I wouldn't take them. I've run the gamut. I started out with yam cream.
Oh, yes.
Good old yam cream. And went up the line, up the hierarchy until I didn't have a choice. Didn't have a choice. So the 90s, I actually started taking hormones. Then this was in the 90s. As I said, I would put people on them.
Right.
Because back then, I mean, you realize there's a whole generation of doctors who know absolutely nothing about menopause or hormones or whatever, because they've not been taught.
Right.
We were actually taught. But there's a 25-year period where they literally have had no education in reference to hormones or anything.
Right. Because when that study came out, said causes cancer, everything stopped.
The panic hit the roof.
Yeah.
Everything stopped.
Yeah.
Everything.
Yeah. Yeah. And now, of course, the tide has changed. And
well, it's unfortunate because the Women's Health Initiative study was so flawed, number one, and so wrong, number two. And it was debunked within 2 years. But whereas when it was put out there. It was headline New York Times and headline Washington Post and headline Wall Street Journal. When it came out that it's not so bad after all, there's only one arm of the study that was a real problem. And even that one wasn't so bad. The one that said there was more breast cancer. There was more breast cancer, but it was not statistically significant.
Right.
Instead of 4 women per 1,000, it was 5 women per 1,000. You don't have to be a statistician to know that that's not, it was actually 4.8 women, you know, rounded up to 5. Okay, that was not statistically significant. But nobody ever saw the 2 columns on page 30, which is where it was. Little columns on page 30. Reassessment of the data in the Women's Health Initiative study says it's really not so bad after all, and hormones actually can be used.
Right. Right. But once that genie's out of the bottle,
that's
it's splashed across. It's very frightening for women to say, yes, I want to start hormone replacement therapy.
I had somebody today tell me she was still not comfortable, despite all the proof that I'm giving her.
Okay.
Hey.
Yeah.
The sad part, however, is there are a lot of clinicians, because they were never trained in it, who are still perpetuating fear-mongering that's gone on.
Right. Right. And that's when someone has that as a patient, if you've got that in your head, that is a very hard thing for a practitioner to break. Like you said, you just had that today. It's a very hard thing to break. And so obviously this is probably one of the myths of menopause that, we're going to cover today, but can we talk about, since we're on the hormone replacement, can you differentiate between bioidentical hormone therapy and traditional hormone replacement therapy?
What we had back then was the traditional hormone replacement therapy. As I said, there was one arm of the study that really was concerning. The rest of it wasn't very bad at all when you looked at it. But the study itself it was flawed in that the average age of the women on the study was 64, 65.
Right.
So anybody who had any symptoms, whatever, were not eligible to be a part of the study. So the perimenopausal women, menopause is average age is 51. Perimenopause starts at 39 or 40. So all of those women were not on there because most of them were symptomatic.
Got it.
So they were not eligible to be a part of the study because they were symptomatic. And then in addition to that, the type of hormone that was used was horse's urine.
Right.
Conjugated equine estrogen, CEE. Now, there are still women out there taking Premarin every day. Most of them probably don't know what they're popping in their mouths is horse's urine, even to this day.
Right.
The difference between the conjugated equine estrogen and the progestin, because again, it was mixed in the test tube, it was synthetic. And that part of the study, that's the one that was really bad. The difference between that and what we use now, the bioidenticals are extracted, the diosgenin that is extracted and compounded into estrogen and progesterone,
Mm-hmm.
testosterone. Yes, ladies, testosterone.
Mm-hmm.
We actually, as women, have more testosterone than we have estrogen. A lot of women, a lot of even practitioners don't know that.
Mm-hmm.
We have 10 times less than men, but we have 10 times more testosterone than we have estrogen.
Mm-hmm.
All right. The molecule that is compounded into what we use now are all plant-based. And it's the exact molecule that the human body makes.
Mm-hmm.
The key fits the lock.
Right. Hence the
The
bioidentical
bio,
term.
life, identical, same as.
Mm-hmm.
The key actually fits the lock.
Right.
Whereas the horse's urine was close, but it wasn't the same.
Mm-hmm. Yeah, thank you. That's a great differentiation there for people. And hopefully it gives the listeners a little bit more insight as to what we're dealing with now today. Now, if someone, let's say a listener, a woman out there is listening, and she's in, let's say, perimenopause, or maybe she just hit menopause and she is having symptoms, what kind of conversation can she have with her doctor? What are some questions that she can ask? Let's say if her doctor is not, has never even mentioned hormone replacement therapy to her.
And 7 out of 10 gynecologists will not mention it to her, even today.
Mm-hmm, mm-hmm.
They will not, because they still, even if they don't think that it really is bad, it's not something they are programmed and accustomed to doing and dealing with,
Mm-hmm.
which to me never made any sense. If you come into me, if someone comes into me and I listen to them, examine them, and say, you know, I think you have a thyroid problem, I fix their thyroid.
Right.
Somebody comes in and they have an insulin resistance or deficiency, I'm going to fix it.
Mm-hmm.
I'm not going to let them walk around with 600 blood sugars.
Right.
I'm not going to let them walk around, you know, it doesn't make any sense.
Mm-hmm.
These are hormones. There are 400 different functions in our bodies that are dependent on our hormones.
Mm-hmm.
400. Now, all the hormones, insulin and cortisol and thyroid and every adrenals and everything included. But included in that is estrogen and progesterone and testosterone.
Right.
We know for a fact now that estrogen protects the heart,
Mm-hmm.
protects our vessels, protects our brain. We know for a fact that estrogen maintains our bones. Testosterone not just maintains, but builds our bones, gives us our energy, gives us our libido. I mean, we know what these things do for us. Every cell in the body has hormone receptors. So when they start declining, when the hormones start declining, just about everything eventually is going to get affected.
Mm-hmm.
So it really doesn't make any sense that we're so scared of this. How could something that's been good for you for 50 years, suddenly when you start losing it, it becomes bad for you?
Right.
Does that make sense?
No.
Doesn't. Does not.
No, not at all. And so how could you approach your doctor with that? Because sometimes when people go in to see the doctor, well, like number one, you forget why you're there. And if you're in perimenopause or menopause, you literally might have
Are
forgotten why
going
you're
to.
there, right? You forget what to ask. You don't want to come off as being pushy or a know-it-all, or, I went to Dr. Google first. You know what I mean?
Well, you don't want to come off that way, but especially if you're symptomatic.
Yes.
Now, even people who are not symptomatic, the process is happening.
Mm-hmm.
So you still need and can use the protection. But especially if you're symptomatic,
Mm-hmm.
you really do need, ladies, to bring it up with your doctor.
Yeah.
And go until you find somebody that's going to help you.
Yes.
I have a patient who was referred by another patient who came in, and she was only 43, 44, but she had been suffering for almost 2 years.
Mm.
She had seen 5 different gynecologists. 5. Count them. She waited almost 6 months for an appointment with the head of the menopause clinic at one of New York's premier institutions. I'm obviously not going to say which one. All right? And even she dismissed her.
Mm.
And she said, you're still having regular periods. Yes, you're having these symptoms, but at 42 and 43, I really don't think it's just your hormones. She sent her out of there with a prescription for Prozac, gabapentin, and
Gabapentin.
heard me, and said, see you in a year. She came to me. That's one of the husbands who called and thanked me. She came to me. Her symptoms were so severe.
Mm.
Okay. And within 6, 7, 8 weeks, she felt like a person again. Within 6, 7, or 8 weeks,
Yeah.
felt like a person again. Because she didn't have a gabapentin deficiency. She didn't have a Prozac deficiency. She
Right.
didn't have a Veoza deficiency. She had a hormone deficiency.
Mm-hmm.
We corrected her hormone imbalance, and she is now a happy camper.
Mm.
And we are protecting her. Bones, skin, brain, we are protecting her. Do you realize bones, osteopenia, osteoporosis, little old ladies who break a hip, 50% of them don't live a year.
That's correct.
That is an actual statistic. I'm lying, it's 48.9, but guess what? 50% of them don't live a year. That has to be worth something.
Yeah, I think so.
I know so.
Yeah. Yeah.
I don't think so. I know so.
Yeah. 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 And, that we can go off on a whole other tangent on people being believed, especially women, when they are going to see their physicians I won't even say physicians, healthcare practitioners in general. So you're right. I think you just have to find the right physician.
We have to advocate for ourselves.
Yes.
You have to do your homework, ladies, and you've got to advocate for yourself.
Yes.
You've got to go until you find somebody who's going to help you.
Yeah, absolutely. Absolutely. And we all go through it. I went through it as well. And I'm happy to report that I found a physician here in New York who's just lovely and listened and is like, okay, here's the plan. And I was like, great, this is exactly what I wanted. Thank you. Now, to help educate these women out there and men, I might add, men and women listening, let's talk about the top 5 myths of menopause that we can start busting today. So we might have touched on a couple already, but I will throw it over to you to talk about those myths.
Well, the top 3, the top one usually is that people think that menopause is just hot flashes.
Yeah.
And menopause is not just hot flashes. Anything related to what your hormones can affect could be a symptom. There are 34 primary symptoms. There are another 20 secondary symptoms, and there are 60 or 80 tertiary symptoms.
Right.
You know, so I mean, there are things which you work the person up, and it's like, wait a minute, I found absolutely nothing. I wonder if it could be her hormones. Do you know how many people come to me with just palpitations?
Mm.
I mean, that's the only symptom. And when they start running out of their hormones, guess how it presents? 3 o'clock in the morning, doom, 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 doom,
Mm.
doom, doom, doom.
Yeah.
Heart's beating out of the chest. All right. There are so many symptoms, not just the vasomotor ones.
Right.
And luckily, we have treatment which will address all of them. A big portion is the brain stuff, the anxiety, the irritability, the panic attacks.
The rage, as we said before, the rage.
I told you, I would clear the hallways.
Yeah.
Okay. Yeah, and the thing is, you give them, okay, gabapentin. Will it help? It will. But that's not the basic problem. That's not the cause of the problem.
Mm-hmm.
Fix the hormones. And when you fix the hormones, the symptoms will go away.
Mm-hmm. Yeah, and there's plenty of symptoms out there. I encourage people to do a little research on their own and look up a lot of those symptoms, because some are kind
You
of
have to think of
surprising.
it.
Yeah.
You have to think of it.
Yeah.
You know, like this woman, another one that's a myth, like this woman, and as I said, it still blows my mind. I mean, mind blown. The head of the menopause clinic is telling someone in perimenopause that because she's still having regular periods, she is not perimenopausal or menopausal.
Right. Right. Well, the definition, like if you're in perimenopause, you're still having your period, because your period, menopause isn't until 1 year of no period.
That is correct. By
So
definition, menopause is 1 day.
1 day. That's right. It's one day.
You're perimenopausal for 10 years or more. You're menopausal for 1 day.
That's right.
And then you're postmenopausal.
That's right.
The rest of your life.
That's right. Yeah.
Which is the other thing. I've had people say, when can I stop this? And I'm like, well, you can at any time, but I'm not going to stop until I'm being viewed. When they're walking by, you will know that I have stopped.
Right. Yeah, no, that's great. So we've got menopause is not just hot flashes. There are many more symptoms. If you're in perimenopause, you're having symptoms, even though you're on your period, and there are treatments for that. There are ways to help regulate those symptoms. What's another
one,
myth?
as I said before, testosterone is critically important. And that is something even the people who do give hormones a lot of times don't use and don't give testosterone.
Mm-hmm.
Testosterone is a little different than estrogen and progesterone, because with estrogen and progesterone, we are fine, then we fall off a cliff and crash and burn. With testosterone, as with men, we lose a little bit at a time. So it's a little bit different in the way it declines.
It's not as stark.
It's you don't fall off a cliff, you don't crash and burn. But you still lose it. So it still needs to be replaced. All right. So that's another very important, because as I said, it's responsible for your energy, your, rebuilding your bone, your libido. It's responsible for all the things that it is in men. It is just as responsible for in women.
Yeah.
So that's another one. What else?
How about here's something that I've always been kind of curious about, and that is, can there are a lot of different ways to replace hormones, but it can one be, let's say you're in perimenopause and you're having symptoms, can going on something like the pill or an IUD help?
Okay. And that's been used traditionally. The problem with that, there are multiple problems with that.
Mm-hmm.
One, those are still the bad hormones. Bad is in quotation marks. Those are not bioidentical, number one.
Mm-hmm.
Number two, do you know that the same doctors who have no problem writing a prescription for a pill for a patient, no problem doing that, but have a problem with bioidenticals? Bioidenticals is less than 10 times, is 10 times less, rather, the amount of hormone that's in the pill.
Oh, interesting.
So
Okay.
not only is it the bad hormones, the synthetic hormones, the horse's urine hormones, but it's 10 times more than we give when you get bioidenticals.
Interesting. Okay, well that's definitely a big myth. And are there, bioidentical hormones are certainly better tolerated, but are there still risks to taking them?
There are obviously risks. As I said, there was a slight increase in breast cancer.
Mm-hmm.
There are different, the way you take them is important, because whether you're doing like creams or sublinguals or injections
Or patch is a
or
patch.
patch, the patch as well.
Uh-huh.
Yes. Um, how much you absorb is dependent, kind of, sort of, on the way you take it.
Got it.
All right. So
Mm-hmm.
there are risks, but they're not anything near or comparable to the benefits.
Got
The
it.
benefits are far, 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 far outweigh the risks.
Mm-hmm.
I'll tell you, there are now even studies where there's a woman at the Cleveland Clinic who have all these papers out there, Dr. Rebecca Glazer, Glaser, not Z, and she has all these papers out there. She and I trained together 30 years ago in,
Mm-hmm.
in hormones, with, using bioidentical hormones. She was at the time a breast surgeon at the Brigham in Boston.
Okay.
And 5 years later, she moved to the Cleveland Clinic, and became head of their BHRT program.
Mm-hmm.
She, even with somebody who had an estrogen dependent tumor, she waits a year and puts them back on it. Now, if it was estrogen dependent, she doesn't give them the estrogen.
Mm-hmm.
But testosterone, when you get down to the bottom, the hormones all morph between each other.
Mm-hmm.
If one receptor is full, it just goes to another receptor.
Mm-hmm. Yeah.
So they're all doing this.
Right. They're all
Testosterone goes to
moving.
estrogen, goes to
Got it.
back
Got
and
it.
forth.
Okay. Well, I'd love to hear that there's a lot of different options. And I think it's great for the listeners to know also that there are a lot of different options out there that can help them as they transition from perimenopause to one day of menopause to postmenopause.
Post-menopause.
And that's, as we mentioned before we went on the air, I did a talk earlier this year for the New York Physical Therapy Association. And one of the questions I asked was, how long is menopause?
One day.
And people were like, a year? A year. And then one woman raised her hand. She was like, 1 day. And I was like, you got it. It is 1 day. So that's another myth that I feel like needs to be busted, because the way that you like words matter, the
Yeah.
way that we discuss this matters. And it's like you said, at this point, we really need to be our best advocate and educate ourselves as much as we can.
Another myth that I think should be brought up
Yeah.
is people will say, can't I just do this with diet and supplements and what have you?
Yes.
Lifestyle is amazingly important, but it doesn't cure menopause. It's very important, but it does not cure menopause, right? So you do need to exercise. You do need to drink enough water. You do need to eat right. You do need to take your vitamins, especially vitamin D and the Bs. And, there are certain things that are really important, anti-inflammatory stuff. You do need to do all of this, but that's not going to cure your menopause.
It can augment things for you.
It helps.
For sure. It helps
tremendously.
Yeah.
It helps tremendously, but it's not going to replace the hormones that.
Yeah.
You know something which I'd like to say here?
Yes.
Your great-great-great-grandmother and mine didn't live past 50. The average age of death in the 19th century was 52, 53.
Didn't have to worry about any of this.
They didn't have to worry about any of this.
Yeah.
The average age of life for a woman now is 86.
That's right.
And for a man is 79 or 80. We're living a quarter to a third or more of our lives after this stage.
That's right. And so we still have a lot to do.
We do.
And what I found really interesting is that in this perimenopause through to postmenopause time is usually the time in a woman's life where she has her greatest earning potential, right? Where she's maybe juggling children, career, older parents, a lot of responsibilities. And
what do they call it? The sandwich generation?
Sandwich generation. And so are we expected to do all of this with hot flashes and rage and increased cholesterol and belly fat and et cetera, et cetera, et cetera? Like, I don't think so.
Which is another thing. And I'm glad you brought up something like increased cholesterol, because that also plays into this.
100%.
Your hormones help with that as well.
Tell me about it. My cholesterol jumped 30 points in a year. Right? So I made diet and exercise changes. It went down 15 points in 5 months, which is great. But I think I might need a little extra help.
Yeah, it really is really important.
Yeah. And that's like, people don't realize, wait, cholesterol, belly fat, belly fat, of course, can lead to visceral fat, which is its whole host of other problems, decreased extensibility of our vessels, right? Which means that our vessels aren't expanding in order to carry blood through. I mean, there's a lot happening here. And some of it you can't see. So when doctors say, well, you're not having any hot flashes or night sweats, so you seem to be okay. And you're like, hold on.
It's not just hot flashes and night sweats.
Yeah, I'm much more worried about a change in cholesterol when in my family I have a history of heart disease, right? Like, that's much more concerning to me.
Physical strength.
Yes, we lose. Absolutely.
We
And
lose muscle.
Lateral hip pain, frozen shoulder, joint aches, muscle aches, all of it. Yep, all the above. So there's a lot more out there. Like you said, that myth number one, it's more than just hot flashes. So hopefully the listeners got a really good education from you today. But what are some of the highlights that you want people to walk away with from our discussion today?
Highlights.
Yes.
Number one, hormones are not dangerous. Hormones are necessary because they were necessary for 50 years. They're still necessary going forward.
Mm-hmm.
That's number two. You have to do what you have to do in terms of lifestyle changes, eating right, exercising, and all of the above. But an integral part of that is balancing our hormones because they are protective. That's number three. They are protective. They're cardioprotective. I mean, you can think of a man who had a heart attack or a stroke at 45 or 50. Women don't start having heart attacks and stuff till 65 and 70 and 75 because of our hormones.
Right, right. And also, when you look at like Dr. Mosconi's work, also at Cornell on brain health.
Yep.
And she's like, well, wait a second. Women aren't getting Alzheimer's because they live longer. We're seeing changes during perimenopause and menopause because of the lack of hormones.
Because of the lack of hormones. And the other thing is, it's, you know, we worry about going through menopause, but it actually should be liberating. Because up to this point, you're worried about getting pregnant. You've got a house full of kids, even if by this time they're older. And you're not, we as women actually should look forward to this period, trying to figure out how to say it. Look forward to this because we're now older and wiser and don't have to worry about the things we had to worry about before.
Right. It can be a very empowering time of life.
Absolutely. Absolutely.
Yeah.
Empowering.
Yes.
But we have to learn to advocate for ourselves because it's not going to happen unless we do it.
Correct.
It is truly not going to happen unless we do it.
Correct. Couldn't agree more. And on that note, where can people find you if they want to consult, they want to reach out to you, they have questions? Where can they find you?
I'm on Madison Avenue in New York City, right in the hub of things. And I'm on a mission. I'm on a mission. You know, the story of the girl throwing the crabs back in the water and the person saying to her, look at all these crabs. You can't throw them all back in. Why are you doing this? And she picked one up, threw it in and said, made a difference to that one. That's where I am now. I'm on a mission because, as I said, what started me up was the head of the menopause clinic telling someone, come back in a year, take your Prozac, take your gabapentin, your Veoza. You're not in perimenopause. It really is important, ladies, that we start as soon as possible. The earlier we start, the better, because then you're not playing catch up.
Right.
The earlier we start, the better, because then you're not playing catch up. So as soon as possible, bring it up with your gynecologist. Bring it up with your gynecologist and start getting replaced.
Yeah. Great. And we'll have links to Dr. Harris's website is drmarciaharris.com. So whatever platform you're listening on down, if you scroll down into the show notes, one click will take you to all her information. She's got a great website. It's really thorough. And you can check her out there as well.
I have a free gift for anybody
Oh,
who a toolkit, and we'll send you what I call my ultimate menopause survival toolkit.
perfect. Perfect. So we'll have a link to that as well in the show notes. Thank you so much. That's wonderful. Now, before you go, I have one question that I ask everyone, and that's knowing where you are now in your life and your career. What advice would you give to your 20-year-old self? That young lady starting medical school, getting ready.
The advice I would give is live your passion. Find what you are passionate about and live your passion. Live your life, but live your passion. This way, you will, they say if you love your job, it's not a job anymore. Live your passion. I used to do a lot of speaking to high school kids and that type, young women. And I used to tell everybody, oh, you got to go to medical school. You got to go to medical school. I don't do that anymore. Now I ask them, what do you see yourself doing 5 years from now, 50 years from now? And you're going to, as far as you're concerned, feel the same way about it. That's what you need to do. If it's plumbing or cleaning toilets,
Right.
or doctoring, lawyering, whatever it is.
Or the theater in your case.
There you go. Live your passion. I have actually tried to get my daughter to become an actress. And now my granddaughter.
It'll happen one day.
It'll happen one day. My daughter actually promised she was going to do it and then reneged on that. And now my granddaughter can sing. So she could do it, but now she wants to be a lawyer. Oh, well, what can I tell you?
Oh, well.
She's also going to live her passion.
Exactly.
And that's really what it comes down to, ladies. Live your passion. The only other thing I will say is, please, you have to advocate for yourselves. Nobody else is going to do it.
Absolutely.
Advocate for yourself. There are people like Dr. Litzy out here who are going to help, but you've got to advocate for yourself.
Yes, great advice. And Dr. Harris, thank you so much for coming on. This was great. So much good information. If you saw me with my head down, I was taking a whole bunch of notes on this. So thank you so much for coming on. And again, everyone, if you want to learn more, go to drmarciaharris.com. Thank you again. I really appreciate it.
Thank you so much. Thanks for having me.
My pleasure. And everyone, thanks so much for tuning in. Have a great couple of days and stay healthy, wealthy, and smart.